So we're still on our lithium series, and today we will be discussing episode 5, lithium toxicity. We want to spot it before it gets toxic. Lithium is like walking a tightrope, steady and powerful when you are balanced. But one wrong step, things can go downhill so fast. The tricky part is that toxicity doesn't always scream right away. It creeps in. It starts in the stomach, moves to the brain, and if it is missed, can end up in the ICU. For both the exam and real practice, you've got to know not just what happens, but why it happens. So let's break this all the way down. Simple, logical, and unforgettable. First, you always want to remember that lithium has a narrow therapeutic window. Here's where it all begins. Lithium safe zone is narrow. It's like threading a needle. So normal will be 0.6 to 1.2, and above 1.5 milliequivalent will be considered toxic. Severe toxicity will be greater than 2.0 to about 2.5, and when you are above 2.5, it can be life-threatening. Why is the margin so small? Because lithium is a simple ion, just like sodium. It is not metabolized by the liver. So even a small change in hydration, sodium levels, or kidney function can cause a big jump in lithium concentration. And this is so important because the boards love this concept. Stable dose, new dehydration, and you're left with sudden toxicity. So let's get into how dehydration can trigger toxicity. Let's look at the chain reaction. Your kidneys filter both sodium and lithium the same way. So when your patient is dehydrated, maybe from vomiting, or they had the flu, or excessive sweating, the kidneys try to save sodium. And guess who sneaks back in with sodium? So the result is lithium buildup in the blood, which equals to toxicity. So if you see a patient on lithium with vomiting, diarrhea, or flu-like symptoms who suddenly has tremors, the answer is lithium's toxicity from dehydration. That's obviously what's going on with that patient. Let's talk about hyponatremia and why hyponatremia raises lithium level. When sodium is low, the kidneys panic and try to reabsorb as much sodium as they can. And again, lithium tags along. So low sodium is going to equal high lithium. For your exam, if you see hyponatremia in a question stem, always think toxic lithium levels, even if the dose never changed. Let's talk about potassium and cardiac risk. Potassium doesn't directly change lithium clearance, but here's the trap. When potassium is low, the heart's conduction system becomes unstable, and lithium already affects cardiac conduction. So low potassium plus lithium is a setup for arrhythmias. And this is another exam favorite. Elderly patients on diuretics and on lithium develops new arrhythmia. What would be your answer? You are looking at cardiac toxicity, even if the lithium levels look normal. Also think of drug interactions. Let's talk about the toxic trio. When we talk about drug interaction. If you remember nothing else, remember this trio because they always show up on your exams. NSAIDs decrease renal blood flow, and when renal blood flow decreases, there's some form of impairment in that kidney and lithium builds up. Thiazide diuretics causes sodium loss, and when there's reduced sodium, remember, lithium is reabsorbed. ACE inhibitors and your ARBs, they lower GFR rate. That means we're going to have less lithium clearance, which may lead to toxicity. Other sneaky culprits may be your metronidazole, which is your flagyl, loop diuretics, and low salt diet. So even one of these added meds can push an individual who is stable straight into toxicity. So you want to pay attention to questions like if a patient is on lithium and they had a headache and decided to go over the counter and buy some NSAIDs. That answer should be directing you towards toxicity level associated with lithium. renal impairment and age. Lithium is 100% cleared by the kidneys. So as your patients age or grow older, GFR naturally declines when people grow older. So the same dose can suddenly become toxic. Chronic use of lithium can also cause interstitial nephropathy, further reducing clearance. For your exam, when you see questions that addresses an individual that is on a stable dose become toxic in patients with new CKD, that's a classic question. So anybody on a stable dose and develop new chronic kidney disease, this is a recipe for increased lithium levels that can lead to toxicity. Let's look at the clinical progression of toxicity. Let's organize the symptoms by stages from the stomach to the brain. Remember, early 1.5 to 2.0, that patient might begin to experience nausea, vomiting, and diarrhea, and fine tremors. With moderate toxicity from 2.0 to 2.5, that individual begins to experience coarse tremor, ataxia, confusion, or slurred speech. With severe toxicity, we begin to see seizures, coma, and even death. Key difference that you must pay attention to is that fine tremors is associated with side effects of lithium, and coarse tremor is a toxic warning sign. So this simple distinction alone can help you answer multiple exam questions. So we understand side effects and toxic levels associated with lithium. So how do we manage issues when they arise? What do we do? Step 1, stop lithium. Never reduce the dose if the patient is symptomatic. You stop it. Mild, you want to hydrate and monitor. Moderate, you want to hospitalize, IV fluids, and ECG monitoring. Severe, they're going straight to hemodialysis. Lithium doesn't metabolize. Dialysis is the only way out in severe cases. Remember, it is excreted through the kidney. So severe cases is an emergency. Let's look at some clinical example. A 62-year-old woman with bipolar disorder presents with nausea, diarrhea, confusion, and coarse tremor. She recently started hydrochlorothiazide and ibuprofen for arthritis. So labs show sodium 128, potassium 3.1, creatinine 2.0, lithium 2.3. So let's unpack this. Number 1, there's hyponatremia. Sodium level of 128. What happens here? The kidneys will reabsorb lithium. Remember, hyponatremia. The body is trying to hold on to sodium. So the kidneys will reabsorb because it can't tell them apart. Lithium is a salt too. Hypokalemia increases cardiac risk. So when potassium levels are down, you're looking for options that is associated with cardiac risk. NSAIDs plus thiazide diuretics, both of them will reduce lithium clearance. Chronic kidney disease, the kidneys can't eliminate lithium properly, so it would also lead to lithium toxicity. So your answer here is lithium toxicity from multiple risk factors, and your management is to stop lithium. You want to hydrate, hospitalize that patient, and dialysis might be considered. So this case captures exactly how exam questions combine physiology, pharmacology to test clinical judgment. So let's wrap things up. Lithium toxicity isn't random. It is predictable. Okay? The big 5 triggers are dehydration, hyponatremia, potassium imbalance, drug interactions, and renal impairment. For the exam, if you see lithium and vomiting, or lithium plus diuretics, or lithium plus NSAIDs, your answer is definitely going to be geared towards toxicity every single time.